A very good morning, students. Myself, Dr. Arya Assistant Professor in the Department of Pediatric and Preventive Dentistry, Vinayaka Mission Sankaracharya Dental College, will be taking a lecture today for you on the topic Topical Fluorides. This topic will be covered under the following contents: the introduction, the definition, the indications for its use, the classification of topical fluoride agents, the different agents or the fluoride compounds that we use for topical fluoridation, and we will be describing each agent in detail. Further, I will also be talking in other self-applied topical fluorides. I am giving a brief conclusion. As we all know, fluorine is an electronegative ion, and in the current scenario, we know we are facing a global burden on of a condition known as dental caries. Now, fluoride has been found to be a single most effective weapon in our limited arsenal of anti-caries agents. In early 1940s and since a long period of time, many studies have shown that the level or solutions of fluoride, when placed on extracted teeth, the fluoride gets completely bound on the enamel surface, which was less soluble than the original enamel surface. So coming to a basic definition, this term topical fluoride is used to describe those delivery systems which provide for a local chemical reaction to exposed surfaces of the erupted dentition. At this point, I would like you all to know that there are two broadly the delivery systems in which fluoride can be provided. One is the topical fluoride system, which we are discussing today, and there is also another delivery system, that is the systemic fluoridation. In topical, we apply topically on the erupted teeth and it causes a local chemical reaction, whereas for systemic fluoridation, it is giving a systemic bodily reaction. Coming to the indications for topical fluorides. The key indication is in caries active individuals or children who are more prone to caries. Another indication is when it can be applied shortly after eruption. It can especially be used as a preventive measure, especially in children who have a condition known as xerostomia, which is most commonly found in children who are taking certain medications that decrease the salivary flow, or children who have been exposed to radiation. Another indication is in children with fixed or removal prosthesis, and also can be a very good preventive measure in children who are mentally and physically challenged. So now coming to the classification of topical fluorides. Topical fluorides, as I said, it is a local delivery system, and this can be delivered very broadly in two forms, either professionally or home, that is self-application. Under self-application, we have different modalities which we can use, which most commonly we have is the fluoride dentifrices and the fluoride mouth rinses. Professionally, we have gels, solutions, foams, etc., in which the most common agents we use are sodium fluoride, stannous fluoride, and acidulated phosphate fluoride. So these agents, as discussed, sodium fluoride, which is most commonly used, followed by stannous fluoride and acidulated phosphate fluoride, are few of the most common agents used. However, there are also other agents such as amine fluoride and monofluorophosphate which can be used. So now first we will be discussing on the professionally applied topical fluorides. Coming to the first agent, that is sodium fluoride. So the studies on sodium fluoride began in 1941 by Bibby and Knutson. The advantage of using this fluoride compound is that it is relatively stable when kept in a plastic container. That is, it has a good shelf life, and so it does not require preparation for every patient during every appointment. It can be stored, and the taste of the same is also been known to be well accepted by patients. However, it has one disadvantage, that for its application, this child requires to come for multiple visits within a very short limited period of time. Coming to the method of preparation of sodium fluoride, we use for topical fluoridation is a 2% of sodium fluoride. For this, 20 grams of sodium fluoride powder is mixed in 1 liter distilled water in a plastic bottle. The specificity of using a plastic bottle is because you should not be using glass bottles or glass cylinders. Why? Because this fluoride can react with the silica in glass to form a compound called silica fluoride. Now, if this compound is formed, it actually decreases the availability of free fluoride ions which is needed for topical fluoridation. So, when we are storing the sodium fluoride solution, it should be stored only in plastic bottles. The method of application of sodium fluoride is also referred to as the Knutson and Feldman technique, which was first given in 1948. It starts with cleaning and the polishing of the teeth and given proper isolation of the cotton rolls, and once your teeth has been completely dried, the 2% sodium fluoride can be applied thoroughly from one quadrant onwards. First, the first quadrant on which it is applied, the teeth is allowed to dry for 4 minutes. Then we continue with the remaining quadrants. It is important to give the strict instructions to the patient after the fluoride application that they should avoid drinking or eating or rinsing for another 30 minutes, and this is so that we can prolong the availability of the fluoride ions on the tooth surface. Coming to the mechanism of action, once the sodium fluoride is applied on the tooth surface, it reacts with hydroxyapatite. Now, the most dominant product that we get from this reaction of sodium fluoride with hydroxyapatite is calcium fluoride, and there is a high significance in knowing this dominant product of this reaction is because of something known as the choking off effect. The choking off effect is wherein once the calcium fluoride product is formed, and as the reaction continues, the product keeps forming, what happens is after the initial rapid reaction, suddenly you find a drastic reduction in fluoride intake. That is, this calcium fluoride starts to form like a barrier around the tooth surface, and which limits the penetration of further any more fluoride ions into the tooth surface. So, this calcium fluoride product however makes the tooth structure more stable, less susceptible to the dissolution by acids, and also helps in the remineralization of initially decalcified areas. Coming to the next agent, that is stannous fluoride. Now, the properties of this is that it is in its aqueous solution state, it is not stable, unlike how we found in sodium fluoride, which has a good shelf life. Since it is not stable because it undergoes fairly rapid hydrolysis and oxidation forming its products, it is required to produce or to prepare a fresh solution of stannous fluoride during every application for every patient. This becomes a major disadvantage for the use of stannous fluoride. Additionally, it has the disadvantage of having an astringent and disagreeable taste. Coming to the method of preparation. In case of sodium fluoride, we found that we use 2% sodium fluoride. In case of stannous fluoride, we use an 8% of stannous fluoride for topical fluoride application. And for this, capsules of 0.8 gram powdered sodium stannous fluoride is dissolved in 10 ml of distilled water in an airtight plastic container. Note again a major disadvantage of stannous fluoride, that it has no shelf life and needs to be freshly prepared for every patient. Coming to the method of application of stannous fluoride, which is also referred to as the Muller's technique. In this technique, we use a technique known as paint-on technique, in which the stannous fluoride is applied with this technique of the solution and is kept for 4 minutes on the tooth surface. The mechanism of action of stannous fluoride. Once stannous fluoride has reacted with hydroxyapatite, it gives 4 major products. The first product that we find is known as tin trifluorophosphate. The tin trifluorophosphate has the property of making the tooth structure more stable and less susceptible to caries. But besides this product of tin trifluorophosphate, there are other 3 major products, that is tin hydroxyphosphate, calcium trifluorostannate and calcium fluoride. Now, in the reaction consisting of a high concentration of stannous fluoride, we find the two products, that is calcium trifluorostannate and tin trifluorophosphate. Calcium fluoride is found when it is present in both high concentrations or low concentration of stannous fluoride, and in low concentration of stannous fluoride we come across the byproduct of tin hydroxyphosphate. So tin hydroxyphosphate helps, it dissolves in saliva, and as we had earlier said, it has an astringent and a distasteful feeling in the mouth. That metallic taste is because of this byproduct, tin hydroxyphosphate. Another product, that was the tin trifluorophosphate, is the main end product, which was, as mentioned earlier, makes the tooth stable and less susceptible to dental caries. And calcium trifluorostannate is also found to have similar properties as tin trifluorophosphate. Coming to the next agent, that is acidulated phosphate fluoride. Now this fluoride only requires 2 applications or biannual application. It's available in the form of gels, solutions and forms, and is most commonly used in its gel form. It can also be self-applied, and the cost of application can thus be highly reduced. Its advantage is also that it is stable and is ready to use. However, it also has an acidic, bitter and sour taste. It cannot be stored in glass containers and is always stored in opaque plastic bottles. Coming to the method of preparation of acidulated phosphate fluoride. Acidulated phosphate fluoride, you use the percentage of 1.23%. It can be prepared by dissolving 20 grams of sodium fluoride in 1 liter of 0.1 molar phosphoric acid. Here we have to understand that the acidulated phosphate fluoride, we ensure that the acidity of the solution is decreased. Okay, we try to make it a more acidic solution. Coming to the method of application, which is also referred to as the Brudwall's technique, it is, as I earlier said, semi-annually or biannual application, and before its application you need to do a complete thorough prophylaxis, give isolation with cotton rolls, and then the solution is continuously and repeatedly applied, because the reason for which I will be explaining in the later slides. You need to continuously apply every 15 to 30 seconds for a total of 4 minutes. So this is explaining the technique of the acidulated phosphate fluoride application. The preferred technique is the paint-on technique, whereas for when you are using a gel form of acidulated phosphate fluoride, you can use the tray technique. Over to the video.
Selection of fluoride trays is available for the clinician's use. There are 2 tray types that can be utilized, one for the maxillary arch and one for the mandibular. These trays also come in a variety of sizes, small, medium, and large. With gloved hands and the patient in an upright position, select the appropriate fluoride tray that will cover the patient's entire exposed enamel. The complete dentition must be covered, including the anterior and posterior teeth. Dispense a narrow ribbon of fluoride gel into the selected trays, no more than 1/3 of the tray height. Make sure to have the fluoride gel spread evenly throughout the tray. This may be done by pressing the sides of the tray together. The fluoride gel can also be spread by tapping it on a hard, clean surface. Another method to spread the fluoride gel is to use a cotton tip applicator. For easier access, it is recommended that the clinician place the filled trays on the bracket table before starting the fluoride procedure. Remove the patient's cup to ensure that the patient will not rinse after the trays have been removed from their mouth. Standing in the 8 o'clock position, the clinician will place the mandibular tray first. Holding the air and water syringe with your dominant hand, retract the patient's cheeks with the index and middle fingers of the non-dominant hand. Dry the patient's teeth thoroughly and remind the patient to stay open to keep the teeth dry. Make sure to dry the facial, occlusal, and lingual surfaces. Without removing the fingers, insert the mandibular tray over the teeth. Lift the patient's lower lip around the tray. The patient's head should be tilted forward at this time to avoid ingestion of excess fluoride. And a saliva ejector should be placed under the tongue. Standing in the 9 o'clock position, the clinician will insert the maxillary tray. As mentioned previously, the clinician retracts the cheeks and dries the teeth thoroughly before placement. Make sure to dry the facial, occlusal, and palatal surfaces. Without removing the fingers, insert the maxillary tray. Lift the lip over the edge of the tray. Once the trays have been inserted, ask the patient to close down and gently chew 2 to 3 times to ensure complete fluoride coverage. This procedure will need to be timed for 4 minutes using either a clock, a timer, or a wristwatch. The patient must never be left unattended during the procedure. After the timed 4 minutes, remove the saliva ejector and both trays. Because the patient has been instructed not to swallow or rinse, ask them to expectorate in the bowl.
Coming to the mechanism of action of acidulated phosphate fluoride. Acidulated phosphate fluoride, after reacting with the hydroxyapatite crystals, initially first leads to the dehydration and shrinkage of the hydroxyapatite crystals. Additionally, we find the first intermediate product which is formed, that is dicalcium phosphate dihydrate. Now this intermediate product, dicalcium phosphate dihydrate or DCPD, is known to be highly reactive. So the fluoride penetrates into the crystals through the openings that has been produced by the shrinkage more deeply, forming the fluorapatite. Now for the conversion of the whole of the dicalcium phosphate dihydrate intermediate product into fluorapatite, it requires deeper penetration and continuous supply of fluoride. This is the reason that while we do the application of acidulated phosphate fluoride, we have to keep continuously applying for every 50 to 30 seconds for 4 minutes. That is, we keep the teeth completely wet at all times for 4 minutes. Now the amount and depth at which the fluorapatite is formed now depends on 2 things, that is the amount of the dicalcium phosphate dihydrate product that has been formed and the depth at which it has been formed. To note is that in this reaction also calcium fluoride is a principal reaction product. So there are certain recommendations that have been put forward to reduce the ingestion during these professionally applied fluoride treatment. The first is, while using a gel, you have to limit the amount of gel that you use. While, as was said in the video, when you are placing it in a tray technique, only 1/3 of the tray needs to be filled. Seat the patient always in an upright position with the head slightly tilted forward and use suction throughout the fluoride treatment. Never leave a child patient unattended while doing fluoride application. Other than the gel and solution, to overcome the risk of overdose, acidulated phosphate fluoride has also been introduced in the form of foams. Now coming to a comparison of these 3 principal agents, that is sodium fluoride, stannous fluoride and acidulated phosphate fluoride. The first is the percentage of how much we use of each agent. As we saw, sodium fluoride is 2%, stannous fluoride is 8% and acidulated phosphate fluoride is 1.23%. The ppm of fluoride is 9,200 for sodium fluoride, 19,500 for stannous fluoride and 12,300 APF. The frequency of application is that sodium fluoride needs to be placed 4 times at weekly intervals at ages of 3, 7, 11 and 13. Whereas stannous fluoride and acidulated phosphate fluoride have a biannual application. Coming to the taste, sodium fluoride has an agreeable taste, whereas stannous fluoride and acidulated phosphate fluoride have disagreeable or bitter taste. So sodium fluoride is stable. Also, acidulated phosphate fluoride is stable if placed in plastic containers. They should not be placed in glass containers, whereas stannous fluoride has no shelf life and needs to be freshly prepared. In case of tooth pigmentation is only found with the application of stannous fluoride, and gingival irritation has also been noted with the application of stannous fluoride. Coming to the next agent that is professionally applied, that is fluoride varnishes. There are many products under fluoride varnishes that has been introduced. The most common that we come across is Durafat. So Durafat is a sodium fluoride varnish which is 2.26% of fluoride or 22,600 ppm fluoride. It is suspended in an alcoholic solution of natural organic varnishes and is also available as suspensions containing 50 milligrams of sodium fluoride per milligram. Going to a video on the application of fluoride varnishes.
Okay, we're all done. That was easy. Now, I want you to remember, you won't be brushing your teeth tonight until tomorrow morning. I also don't want you to eat anything hard or sticky for today. Your teeth is going to look a little bit yellow, but that will go away once you brush tomorrow morning. And after that, I want you to remember to brush morning and night. Helps to prevent you from getting cavities. Okay? We're all set?
Yes.
Very good.
Coming to the advantages of using fluoride varnishes. Our first advantage is that these varnishes once applied sets rapidly and adheres to the teeth. So it reduces the risk of rapid ingestion of fluoride. Besides, saliva is known to promote the setting of fluoride varnishes. Only small doses of fluoride varnishes are required for its application. Gagging or swallowing or any difficulty of that sort is not there, as no tray is used, and also the application time is very short. Because the varnish sets rapidly, patients can rinse to remove any varnish on the gingiva or their mucosa, and also the risk of dental fluorosis is minimal with the use of fluoride varnishes. Moving on from the professionally applied, we will be now discussing is the self-applied topical fluorides. In self-applied topical fluorides, the most common means of self-application or self-applied topical fluorides is the fluoride dentifrices and the fluoride mouth rinses. So fluoride dentifrices, the sodium fluoride was the first fluoride compound to be added to a dentifrice, and it was followed with the use of stannous fluoride. It consists of minimal amount of fluoride of a range of 200 to 1000 ppm fluoride. The drawbacks of using stannous fluoride and sodium fluoride dentifrices was, however, that it lacked a compatibility with the abrasive composition of the dentifrices. Also, it was seen to stain anterior restorations, especially composite restorations, and also it caused a metallic astringent taste which was not acceptable. So, to overcome these drawbacks, another agent was introduced, that is the monofluorophosphate, and now this is the preferred form of fluoride in most of the commercial fluoridated toothpastes. Because it not only overcomes the taste, it also has overcome the incompatibility that sodium fluoride and stannous fluoride had with the abrasives composition of dentifrices. Now, these dentifrices with monofluorophosphate comes with a concentration of 0.76 or 0.1% of sodium metaphosphate as the abrasive agent. The advantage of this is it has a neutral pH, greater stability to oxidation and hydrolysis, a longer shelf life with increased availability of fluoride and with no staining of teeth. When giving a dentifrice, it is recommended to give a smear or rice grain amount for children 2 years of age and pea-sized amount for children aged 2 to 5 years. Last self-applied topical fluoride agent we will be discussing is the fluoride mouth rinses. Now, this is specially indicated as a primary preventive programs both for children and for adults. It can be recommended for use for patients with rampant caries, hyposalivation or xerostomia, patients with sensitivity due to tooth wear caused by abrasions, attritions, etc., or in patients who have fixed or removable prostheses in their oral cavity. However, it is absolutely contraindicated in children under the age of 6 years and need not be also given for children who are living in a fluoridated area or who are under fluoride supplements. It should be used as an adjunct and not a substitute of dentifrices. So, to conclude, the primary caries preventive effects of fluoride results from mainly its topical contact with enamel and through its antibacterial actions. Therefore, the therapeutic use of fluoride for children should focus on regimens that maximize the topical contact, preferably in the lower doses with higher frequency approaches. Thank you all for watching my lecture.